Hello everybody, my name is Chong from Singapore. I'm a vascular surgeon at Singapore General Hospital. I'm delighted to join you this time virtually at the important Korea Society of Phlebology meeting. I'm honored to be invited by the organizing committee, and special thanks to Dr. Hyungjin Oh for inviting me. My talk today is superficial venous disease, a brief overview. I understand this will be in the young fellows section, so this is going to be covering several aspects of this portion. This is roughly what we're going to talk about: some treatment options for superficial venous disease, the various different options shown over here, and at the end I also have some important data for us to consider when we look at the treatment of superficial venous disease. So these are some treatment options. As mentioned, we start with surgical treatment. This has been there for more than 100 years. Compression stockings, sclerotherapy, and the newer, more non-invasive ablation techniques, which I'll go through one by one. We start with surgical treatment. So this obviously requires general anesthesia in the operating room, and it has been very successful and permanent. Obviously, the morbidity is quite high for these patients, as well as the need for hospitalization, which we know in this COVID period is not desirable. These are some of the important studies that describe the outcomes of surgical stripping versus RFA. For the first study, you can see that pain, bruising, recovery time, and return to work is improved with radiofrequency ablation. Similarly, this second randomized controlled trial, multi-center, also is the same. The most famous of these RCTs is likely the Rasmussen one, which randomized 124 and 123 patients to RFA and surgical stripping respectively, and it showed that pain and bruising was improved. With RFA, return to work was improved as well. So all of this has led to more patients wanting minimally invasive options. Next, we move to therapy, which is using a chemical irritant to cause the vein to spasm, collapse, and scar thrombotically. There are large vein sclerotherapies as well as small vein sclerotherapy, the latter being predominantly used for cosmetic treatment of spider veins. I will start with large vein sclerotherapy results, and these are some of the pertinent studies. These are single-centered studies over here, with limb occlusion rates at 1 year of about 70%. In terms of multi-center randomized controlled trials, you can see over here, they can be reflux-free for a not very long period of time, which is actually the Achilles heel for large vein sclerotherapy. So it has poor long-term efficacy in these kind of studies, and I think the results from the data suggest equivalent. Small vein sclerotherapy is a totally different kettle of fish, and I think is a good idea for cosmetic spider veins. We look at laser ablation, and it's basically using optical fiber to deliver laser energy using continuous pullback. This requires the use of tumescent anesthesia. And there are different wavelengths shown over here: 810, 980, 940, 1040, and even longer ones, 1320 to 1470. So the difference is hemoglobin targeted versus water targeted therapy, and difference in laser fiber with bare laser fibers, radial laser fibers, and covered tip ones are also there. When we compare laser with radiofrequency, laser produces the occlusion by boiling blood at 1200 degrees Celsius, creating steam bubbles which indirectly transfers heat to the intimal surface. Radiofrequency, on the other hand, is transferring radiofrequency energy directly to the vein wall at 120 degrees Celsius. So that's the mechanically different ways where RFA versus EVLA treat the vein. If we look at the clinical summary of important randomized controlled trials, shown over here, 3 of them, post-operative pain, bruising seem to be better with radiofrequency ablation than with laser, especially pain here. So these are the 3 important studies that I think we should consider. Looking at now more minimally invasive options, which are the non-thermal, non-tumescent options. The overviews are sclerosant based, and they may also add a mechanical mechanism to close the vein in addition to the injection of the sclerosant. So this includes the Clarivane catheter, or the Mocha treatment, or the Veritina, which was from BTG before. Clarivane, its advantage, it's a 4 French solution. It doesn't require tumescent, and there are many patients who have had this form of therapy. However, there are some issues, especially relating to the valves of the vein wall getting stuck in a rotating wire and thereby causing some pain for the patient. Long-term efficacy is okay, but not as good as some of the other options, which I will showcase. This is the Venous seal closure system, initially from Cephion, and then Covidien, and now Medtronic. This uses advanced cyanoacrylate adhesive, which in short we call it super glue. It's a non-thermal, non-tumescent, and non-sclerosant therapy, and because there is no tumescent anesthesia, we can treat below the knee as the vein as there is no risk of injury thermally to the nerve below the knee. We also do not require compression stockings, which is a huge draw to patients, especially in hot and humid climates. This is the primary endpoint, which is efficacy at 60 months, 5 years. The closure is 93.6%. This is core lab adjudicated, so this is really quite a good result for a durable option. Now, in terms of secondary endpoints, we look at the satisfaction, and most patients are very satisfied with their treatment, and most of them, 93.6%, would choose venous seal again. So I think this speaks to the ease of the procedure as well as the side effects associated with it, and I think this is quite a good treatment option. If we look at some data, then we have the VCLO study, which I've shown just now at 5 years already, versus the Clarivane. And the Clarivane, the closure rate at 88.2% at 1 year is lesser than that at 5 years for the Venous seal VCLO study. So I think there is a bit of difference between the two. For General Hospital, we have embraced this modality since approval by our HSA in 2016. We've done more than 1,000 cases. Patients are pretty happy with them. As mentioned, the lack of need for compression stockings is a big draw. I was fortunate to be featured in our local newspaper, and many patients come to me for the treatment of the super glue. Also partnered with Medtronic to introduce the venous seal to a couple of countries shown over here, and did the first cases in these countries. It's important to note that chronic venous insufficiency is a big problem. It affects all age groups and genders, and is 10 times more prevalent than peripheral arterial disease. So worldwide, the prevalence is expected to be at 20%, and this can be a big problem, especially in terms of progressing to venous ulcer. So I'll go talk about venous ulcer healing and evidence. Evidence of varicose vein surgery in venous ulceration. This is a Cochrane review, and we compare it, the forest plot of meta-analysis of surgical intervention, ablation over compression. And these are randomized controlled trials only, showing that the ulcer heals better with ablation compared to compression. If you look at ulcer recurrence, Then following varicose vein surgery, all studies versus randomized controlled trials is also favoring varicose vein surgery. These are results of meta-analysis, and this is the highest level of evidence we have. Since 2018, we have the EVRA trial shown over here, and it's a landmark New England Journal paper for venous ulcers between 6 weeks and 6 months. And it basically shows most of these ulcers are between 1 month and 6 months. So these are not new ulcers, but have been there for a while. Early intervention with minimally invasive therapy, shown in the top curve, increases the cumulative rate of ulcer healing versus deferred intervention. I think this is really quite important, and so the median time to ulcer healing is decreased, the rate of ulcer healing is increased, and the median ulcer free time also increases. Of cost effectiveness, this is another paper in JAMA surgery, and I'll skip through some of this. They look at early intervention group versus deferred intervention group, like I showed you. And at 3 years, there was cost effectiveness with early intervention group. As a result, now the guidelines show that they have changed to not offer just compression to treat varicose veins unless interventional treatment is unsuitable. I think this is important to know that. So compression is not equivalent to ablation now, and we should offer ablation, and this is an older version of the guidelines, not having the NT options that I discussed earlier. So they should offer ablation over stripping, of course, to most patients. And if we offer compression after interventional treatment, do not use for more than 7 days. So I think patients would like this recommendation very much. I'd like to thank you for your attention on this and wish you a very successful Congress. Take care.